All right. Our program development project is titled Serving Patients More in the Emergency Department. My name is Bella, and I partnered with Maggie, Reagan, Kenzie, and Danielle to create this project.
Okay, so we were assigned to do a needs assessment for University of Colorado Hospital. And Julia Smith, who is an occupational therapist at the hospital working on the geriatric certification team, was our original community partner. And then a couple weeks community partner changed to Megan McShane, who is the senior occupational therapist at UCH. So our target population for this needs assessment are individuals with or at risk for delirium in the emergency department. And delirium is a diagnosis characterized by inattention, disorganized thinking, and altered levels of consciousness. Those at risk for delirium include individuals with dementia or those who are affected by things like infections, urinary retention, immobility, sleep deprivation, dehydration, hypoxia, and more. So as we started our assessment, we originally thought that the need of this population was sensory related, but as we did our research, we found that improved communication between the emergency department staff and the patients with or at risk for delirium was the greatest need. Some of the underlying causes of this need included a person-environment mismatch, decreased presence of occupational therapy in the emergency department, and the common use of sedation and restraint to combat patients' challenging behaviors.
So, the Older Adult Hospital Readiness Tool, originally developed and validated by the Alzheimer's Society of Canada for persons with Alzheimer's, was selected by our team as an appropriate communication tool to address the needs of our target population. We chose this tool because it promotes patient self-advocacy and it briefly assesses several areas of occupation, including communication, health management, feeding, and mobility. The tool is intended to facilitate the assessment process, decrease the use of medications, increase practitioner understanding of patients' prior level of functioning, increase the frequency of client-centered care, and decrease behavioral problems. So, given successful implementation of the tool, staff will have increased knowledge of delirium and the needs of persons with at risk for delirium in the emergency department. Ultimately, successful implementation of the Modified Older Adult Hospital Readiness Tool as a preventative measure could improve patient quality of care in the emergency department, leading to decreased hospital admittance and subsequent risk of contracting further hospital-acquired illnesses, such as urinary tract infections, for example. So successful implementation of the tool could also result in decreased use of sedation and restraint methods in the emergency department, decreased risk of mortality due to undiagnosed delirium, and overall improved patient well-being in that fast-paced, overwhelming environment.
So the goal of our program is to improve communication of people with or at risk of delirium and their caregivers with hospital staff through implementation of the Modified Older Adult Hospital Readiness Tool called the MOAHR. By the end of the semester, we plan to present UC Hospital with information and materials including handouts, evidence, and a program assessment plan for our community partner and the hospital's education team to implement during an appropriate time post-COVID. We hope that within 1 year, our program will aid staff in identifying and addressing underlying needs and preferences of people with or at risk of delirium to decrease the prevalence of challenging behaviors and improve the quality of care in the emergency department. The objectives to achieve these goals include developing a delirium-specific MOAHR tool, educating staff on delirium and communication strategies, and creating a plan to ensure implementation of the MOAHR is effective and sustainable.
So here's a copy of our logic model. I'm going to start on the far left with our resources and inputs. Currently, we have an OT team. They have expertise in the person-environment mismatch between people with delirium and the emergency department. However, they don't have a significant presence in the emergency department currently. So we're also going to be using the UC Hospital team that is seeking a geriatric accreditation. That's a project that they're working on right now. And we have the UC Hospital education team. They approve all of the materials that are used for education within the hospital. We've reviewed the literature on improving the emergency department experience for people with or at risk for delirium. And we also have the OAHR tool that was developed and validated by the Alzheimer's Society of Canada. What we need is a UCH stakeholder team to lead implementation and maintenance of this program. We have talked with Megan, and it sounds like she'll be able to be a big part of this, but we know that it'll also take buy-in from other OTs, PTs, nursing, the education team, and those types of resources. So for our plan, our first activity was to educate staff on delirium and strategies for behavior management. We've decided to create a handout with information on delirium, environmental modifications, and communication strategies for staff members. We hope that this will increase staff awareness of delirium and increase staff use of non-pharmacological behavioral management strategies, and ultimately lead to decreased behavioral incidents in patients without a history of behavioral symptoms and decreased use of sedatives and restraints. Our next activity was modifying the OAHR tool to fit the specific needs of people with or at risk for delirium in the ED. So we call that the MOAHR tool, modified OAHR. And the goal of this is to improve communication between staff and people with delirium and their caregivers. This is especially related to their history, behaviors, and preferences. So it asks about specific patient characteristics, like things that might be agitating and what can help with that. We hope that this will improve the patient experience in the emergency department. We hope that staff will be able to establish patient baseline better with this information, and that would eventually lead to a shortened length of stay for people with or at risk for delirium. Our next activity was collaborating with key stakeholders to create an implementation plan to maximize program success. We talked with Megan for this step of our project and ultimately decided that a post-COVID implementation would be more effective and more likely to be bought into by staff. Everyone's very busy right now, so we're planning on this being implemented when nursing is a little bit more able to take on something new like this. We hope that this would ultimately lead to the MOAHR being easily accessible and regularly implemented with people with or at risk for delirium, and that would increase the frequency of client-centered, family-centered care. Finally, our last activity is advising the UC hospital education team on program assessment procedures. We'd like to create a program assessment plan document to share with them with ideas of what kinds of outcomes we're looking for. This would give us data on staff utilization and perception of the MOAHR and the effectiveness of the MOAHR in improving patient outcomes. And ultimately, we would like to have an effective, evolving, and replicable MOAHR tool to aid staff in providing best care for people with or at risk for delirium.
The theoretical framework we reference throughout our project is the PEO model created by Law et al. Within this framework, we look holistically at the interaction between the individual person, the supports and barriers within their environment, and the desired occupation. All of these aspects influence the overall occupational performance of the individual. For example, in our project, the people would be the individuals with or at risk for delirium. These individuals often have a reduced stress threshold and can become anxious in a new setting. The environment within an emergency department is often busy, overstimulating, and unfamiliar to the patient, which may create a barrier toward occupational participation. The occupation aspect within our project includes all of the typical and valued occupations that patients may engage in, such as health management, feeding, and sleeping. The interaction between the person, environment, and occupation ultimately impacts the patient's ability to perform in their valued occupations. There are several additional resources required prior to the implementation of our project. All of these are estimates, but can provide the University of Colorado Hospital with an idea of what project implementation within the first year might involve. First, we will need a therapy team member within the hospital that is able to contribute about 4 hours per week toward implementation and maintenance of the communication tool, along with any staff trainings needed. We predict the cost of the employee's time to be about $7,000. Second, possible materials and supplies will include the Modified Older Adult Hospital Readiness Communication Tool, which we call the MOAHR, training handouts for staff members, resources for a follow-up survey, and office supplies such as printer ink and paper. We predict this cost to be somewhere around $1,500. Lastly, we will need a staff member on the education team working about 4 hours each week to implement a new documentation tool into existing software, modify the tool as needed, and create a follow-up survey. We expect the cost to be about $7,000. In total, we estimate the final cost to be approximately $15,500. However, there may be adjustments to this number if the stakeholders at the University of Colorado Hospital make modifications to the proposed plan. Here's a quick overview of the references. And thank you guys so much for listening to our presentation. We're looking forward to answering any questions that you may have regarding our project proposal.